Hi, and welcome to part one of the final exam review. I've divided the review modules up into two different lectures. One covers modules 1 through 5, and the other covers modules 6 through 10. My advice to you is to review all these PowerPoints. Make sure you listen to the narration. Essentially, I've just plucked these out of the previous lectures, so each slide might not connect so well to the previous one, but all of these cover concepts that will be on the final exam. So go through them, listen through them, and ask me if you have any questions. I've also posted some supplementary reading that I want you to go through because I will have questions from those readings on the exam. If you have any questions about the material, email me and let me know. I'm happy to review with it. And also, please go back and look at the midterm and go over all of those questions because I will be covering those same topics on the final. Good luck, have a great Thanksgiving break, and get in touch with me if you have any problems. So how do all of these people doing these roles and performing these tasks work together on a project? Well, this is a very simple data or project flow chart. Everything begins with the development of the protocol and ends with the generation of a study report. Once the protocol has been approved, it becomes the basis for an analysis plan. This is where the statistician outlines how they're going to analyze the data, and it tells you what they need to do to perform that analysis. The project team uses the protocol and the analysis plan to develop the case record form, or CRF, the database, and any project-specific plans for activities such as site monitoring, data entry, data review, and quality control. So keep in mind that the protocol and the analysis plan are going to drive the rest of the project flow. Once all the project plans are in place, the functional areas can start to work. Clinical is going to identify, recruit, and train investigators to run the trial. The investigators are going to recruit and enroll patients. Data management will create a database. Data is entered into the database. Data management and clinical will review all that data for discrepancies and trends. Discrepancies are resolved with the investigator. And once all the patients have completed the trial, data management is going to perform a quality control or QC check of the data. They're going to lock that database, and the statisticians can now analyze the data and generate a report. So that's a typical project flow. Let's talk about what a clinical data management system is. You'll also see this with the acronym CDMS. So a clinical data management system, or CDMS, is simply a computer system developed for and used to manage the data produced during a clinical trial. There are two primary types of systems. One is paper-based and the other is electronic data capture, or EDC. Paper-based CDM systems are designed around the use of paper or hard copy case report forms, or CRFs. EDC systems are designed to allow direct entry into a database and don't always use a paper case report form. Remember that the FDA defines a computerized system as a computer hardware, software, or associated documents that create, modify, maintain, archive, retrieve, or transmit digital information related to the conduct of a clinical trial. So this means that CDMS systems have to comply with 21 CFR Part 11, and that the industry was going to expect voluntary compliance with the ICH and FDA guidance documents as well. They're just considered best practice. So what else do we have to deal with a clinical data management system? Well, you're going to need to make certain that it is validated. The FDA defines validation as establishing evidence which provides a high degree of assurance that a specific process is going to work, essentially. This means that CDMS systems used for clinical trials have to undergo a rigorous process of testing to confirm that they do what they are designed to do. We're not going to cover the details of validation in this course, but if you want to explore it a little more in depth, I suggest you read Chapter 23, System Validation, Chapter 24, Test Procedures, or Chapter 25, Change Control, in your textbook. We have to have an audit trail. The FDA defines an audit trail as a secure, computer-generated, time-stamped electronic record. that allows the reconstruction of the course of events relating to the creation, modification, and deletion of an electronic record. So essentially, all of your systems should automatically generate a record of who did what in the database. And over here I have a little example of the audit trail that is generated by REDCap, the system we'll be using. What functions do you find in the CDMS system? Well, most of them support the following functions: database design, entry screen production, data entry, data cleaning, discrepancy management, and query resolution. They also allow you to lock the data, import and export it, and they make an audit trail. So what's the difference between an EDC or a paper-based system? Well, remember that the EDC systems were designed to allow study coordinators or study site staff to enter the patient data right at the site. So EDC systems generally have limited document tracking capability, but strong point of entry checks for data validity. The site can enter the patient data directly into the ED system, or they may record the information on a source document or a paper case report form before they enter it. Paper-based systems were designed to manage paper copies of CRFs. The clinical site would record the data on a paper case report form. It'd be sent to a central data management group, which then entered it all into the database. Paper systems simply, they tend to have really robust document control and page tracking features, and then they also support entry, verification, data review, and all of those other capabilities. There are a couple of common or really well-known commercial systems. Most organizations are going to use a commercial system when they bought off the shelf and not when they wrote themselves. So they are pretty much purchasing the software like you'd purchase Microsoft Word. A really very small number of organizations build their own systems, and those are referred to as proprietary systems. Validating a proprietary system requires an enormous effort, so most organizations just purchase a commercial system and get going. Here are some of the more commonly known systems for EDC. There's Oracle Clinical's Remote Data Capture System, Inform, Metadata Rave, OpenClinica, and REDCap. The paper-based systems, really the leaders in the industry, are Oracle Clinical and ClinTrial. So we've talked about common data management tasks. Now we're going to look at it from a slightly different viewpoint, data management roles. And it's important to remember that tasks are going to be performed by individuals that are assigned to specific roles. But different organizations may assign and structure these roles in various ways based on issues such as workflow, headcount, or organizational structure. For example, some companies combine document control and data entry into one group. Others combine database programming and statistical programming into one group. But the most common data management roles are document and records control. And again, this can be integrated into data entry and data review, or it can exist as an independent function. Individuals performing this role, again, are going to record the receipt of study documents, track their status, and ensure that the documents are stored and later archived in compliance with industry regulations. Database programming is responsible for developing the database and creating supporting programs that are used by the data management team. Data entry can be performed at the clinical site, or it can be performed at a central data management center. Data entry is basically the process of transcribing the data from a source document or case report form and entering it into the CDMS. Data review is reviewing the data to look for clinical consistency or inconsistency, to look for discrepancies or trends in the data. In some cases, data review is being integrated with clinical site monitoring as part of a move towards what we call risk-based monitoring, or RBM. Quality control, again, is a role that can be integrated in with data entry or data review, or it can exist as a standalone role. And essentially what you're doing is looking at the database after all of the cleaning has been done and checking the error rate so that you can make sure you have an acceptable error rate. So what is clinical data management? Our textbook states that clinical data management is the work performed on data from a clinical trial, from the preparation to collect that data through the time it's extracted for final analysis. Clinical data encompasses all the data generated by and related to the conduct of a clinical trial. Examples of clinical data include medical history, vital signs, physical exam, laboratory data, and adverse event data. The goal of clinical data management is to produce complete, reliable data that can be used to answer the question posed in the protocol. The clinical data management team is responsible for ensuring that clinical trial data are integrated into a format that can support the analysis. Regulations govern what we do. All data management activities have to comply with the general standards of good clinical practice. But in addition, there are a few regulations and guidance documents that specifically address clinical data management activities. One that you're going to hear very frequently is 21 CFR Part 11, and CFR stands for the Code of Federal Regulations. This documents FDA regulations governing electronic data records and electronic signatures. 21 Part 11 tells us that we have to validate databases to ensure they're accurate and reliable, that we have to control access to them, and that we have to have a computer-generated audit trail that documents the creation, modification, or deletion of electronic records. Now remember, 21 Part 11 is a regulation. This means compliance with it is required, not just suggested. There are also several guidance documents that we're going to have you read over. One is the Guidance for Industry in relation to electronic source data and clinical investigations. Another is the Guidance for Industry Computerized Systems used in clinical trials. And then we also have the ICH GCP Guidance E6. Section 5.51 through 5.512 relates directly to clinical data management activities. There are some other places where we look for best practice. One of these is the Society for Clinical Data Management, or SCDM. This is an international association of clinical data managers. The group focuses on best practices and has produced several documents defining their view of good clinical data management practices, or GCDMP. Copies of these documents are free to members, and the annual student membership due is $50 if you're interested. I can tell you that your text relies very heavily on the SCDM best practice documents, so you'll get a lot of coverage there as well. In Module 1, we talked about the FDA regulations for 21 Part 11 as well as for electronic data. And we do need to comply with all of those. But in this case, I want to talk specifically about regulations involving standards or standardization. Right now, there are a few regulatory standards for the naming or structure of clinical data. In the past, each sponsor utilized their own proprietary standards and simply submitted documented data sets to regulatory reviewers. However, in February of 2014, the FDA released 3 draft guidance documents, which propose that starting in 2017, all electronic submissions to the FDA will need to comply with CDISC standards. So let's talk a little bit about CDISC. Industry standards are informal expectations for good data handling. Sponsors and CROs will expect you to operate using these best practices. The Society for Clinical Data Management, or SCDM, has published a list of good clinical practice data management documents, or GCPDM. As I noted in Module 1, Proshka has incorporated the SCDM documents into her text, but if you ever need direct access to the documents, you can purchase copies or join the SCDM and gain access to free versions of the copies. Also, remember, while you're not required to comply with FDA and ICH guidance documents like you are with regulations, the industry standard is to follow those guidance documents, so you'll need to be doing that. What is CDISC? CDISC stands for the Clinical Data Interchange Standards Consortium. Over the past decade, there's been a push to develop industry-wide standards for collecting, storing, and reporting clinical data. This effort is being driven by the Clinical Data Interchange Standards Consortium. CDISC is comprised of volunteers within the pharmaceutical industry and various regulatory agencies. The primary CDISC initiatives are C-, the Clinical Data Acquisition Standards and Harmonization Group. C- focuses on data collection, how we name and define the fields we use to collect clinical trial data. The C- Working Group has defined standards for many common CRS, including the AEs and vital signs. Throughout this course, we'll refer to the C- standards. The STDM, or Study Data Tabulation Model, focuses on standards for storing and displaying the study data tables used during regulatory review. The ADAM, or Analysis Data Model, focuses on standards for the organization, structure, and format of analysis datasets and related metadata. This includes standard dataset structures, variables, and naming conventions. We're not going to discuss the CDISC standards in depth in this course, but you do need to be familiar with the major CDISC initiatives, and you need to be familiar with the fact that the FDA is planning to require submissions in CDISC format. If you want to know more about CDISC, I'm going to have you explore their website, and it's going to be part of your assignment.